I'd like to present Dr. Noha Rashad. She's a clinical oncologist and consultant at military medical faculty. She'll be speaking about MEMAGO consensus in epithelial ovarian cancer's roadmap.
Thanks, Professor, and thanks for inviting me to share in this ambitious project regarding developing a consensus recommendations for management of epithelial ovarian cancer in our region. So these are my disclosures. During my presentation, I will try to answer a few questions to convince you with our project and tell you what we are going to do. First, why to develop MEMAGO consensus recommendations, why a consensus, and how we are going to develop a MEMAGO ovarian cancer recommendations. Epidemiologically speaking, ovarian cancer is one of the common malignancies. Yes, it is. And also, as we can see here in our area, the Middle Eastern and Mediterranean Sea area, we have some countries have an moderate incidence and or low incidence, and others have a high incidence. However, the annual mortality rate from ovarian cancer in our area is increasing. However, this is not the main motive to initiate our project of developing a consensus. So let us say that there is a big challenge we have, not on the level of implementing guidelines, but actually on the level of developing guidelines. And let us say it quite clear, one of the main obstacles is actually how much our experts are convinced with the idea. Because besides the complicated methodology and difficult development process of consensus recommendations or guidelines, many of our experts may wonder why to develop guidelines while we have already strong guidelines in our hands coming from a prestigious medical societies. And also, are we going to implement these guidelines? Are we going to take it in our everyday practice? This is beside the high workload. So we have a lot of specific challenges, specific for our area. As we can see, and this map shows the area covered by the MEMAGO, we have a very heterogeneous situation regarding either the access to healthcare services, the approved treatment options, which is not available in many countries, and also wide variability in reimbursement and insurance policies, because we have some countries are developed countries, others of low middle income countries, and others from low income countries. And also we have a very critical situation where we have around 2 million persons are totally deprived of access to basic medical care. International guidelines developed specific guidelines tailored to low or restricted resource areas, just like the ASCO with the resource stratified guidelines, and also variable adaptations by international guidelines to meet the needs in developing countries. However, even with the guideline recommendations developed for limited resource countries, still we have a gap in our everyday practice when we are trying to take these guidelines into our everyday practice, and this is the gap which we will try to cover in our project. So why the consensus form? We have to differentiate between two terms, the clinical practice guidelines and the consensus recommendations. Clinical practice guidelines are these statements which has a very powerful supporting evidence coming mainly from systematic search of literature, and it is based mainly on critical appraisal and critical assessment of the strengths of this evidence. While consensus recommendations are developed by another method, it's actually arising from the agreement between individuals who are actually experts, not just individuals, on a given subject. It is endorsed by scientific societies. However, no systematic search for literature is required, and also the assessment of the evidence is not well structured as the clinical practice guidelines. However, we are trying to overcome the implementation barrier because we have multiple options in this situation. Either we develop guidelines from the scratch, specific for our areas, and this is a very difficult and time-consuming process. However, we can give it up, and by this way we'll deprive our patients of the benefit patients usually gain from implementation of evidence-based guidelines, or we can adapt. We can adapt to the existing guidelines. All of us go somehow through the process of adaptation because we do it either in an informal way, because every one of us in his everyday practice got specific preferences and what guidelines he prefers to rely on in his everyday practice, or on a small setting, on a hospital setting, or institutional setting. Or we have another option, which is a formal adaptation, performed using a guideline adaptation group and an established framework. And so this is what we are going to do. Is actually, we are not going to reinvent the wheel. We are going to look at the internationally approved guideline and trying to put it into context. This context is not just the scientific process and the scientific evidence. We are going to put a lot of aspects in our minds when we are criticizing and revising these guidelines, including the use of resources, the applicability of the guidelines, and the patient values and preferences. This is aiming to reduce the variability in cancer care, and also we will have a lot of gaps that will be identified in our research and highlight our research needs. How we are going to develop these recommendations? Well, we have what is called an adaptive framework, because when we are trying to adapt these recommendations, we have multiple levels. We can take it as it is without modification. This can go in certain situations for sure, or we can adapt it with some modifications. We can develop specific recommendations for specific situations that are pertinent to our area or our setting. However, this is not going to be without an evidence. It should be supported by evidence as well, or we have new evidence that is not criticized enough or revised enough, and we can choose by a consensus way either to adapt it now or maybe adapt it later. The process takes a few steps. The setup phase, in which we are launching today, we are going to prepare for this process. We are going to assemble our panel of experts. We are trying to explore what will be happening during the next few months. The adaptation phase, defining the health questions we will try to address in our recommendations, search and screen the guidelines, assess these guidelines, decide and select which recommendations are going to be adapted without changes, which needs a modification, which type of modification we are going to have, and also what is the evidence supporting every modification we are going to do. Then we will have an external review board in the final phase. This will be the final phase before planning for further review and update as any guidelines. Then we will produce our final guidelines. So the roadmap. First, the planning and preparation phase. We are going to identify and recruit consensus development expert panels. And when we say panels, it's multiple panels, not a single panel. We will have a panel for surgery, surgical oncology, gynecology, pathology, molecular testing, and medical oncologists, defining the consensus scope and the clinical questions we are going to answer, searching literature. Then in February 2024, we are going to have our first periodical meeting, trying to endorse the consensus development process, discuss the final scope, and also agree on the deadlines and launching the process. The first survey will be disseminated, which will be a web-based survey, will be disseminated by March. After collecting the survey voting outcomes, we are going to analyze these outcomes and formulate the provisional statements or provisional recommendations. Some of these may reach consensus, some may not. So we will go for the second step based on the panel member answers on the survey. In the first survey, we are going to further analyze the provisional statements that are going to be developed. And finally, the final voting process that is supposed to take place in September next year. It will be a closed group meeting, a sequential discussion of statements that didn't meet the consensus, and we will have our final voting on the final form of recommendations. During the upcoming MEMAGO event, as I hope, inshallah, we will release the final recommendations for discussion and dissemination, and finally we will reach to the final step, which is the publication. The process, actually the voting process will be using a modified Delphi approach, which is, I think it's well known for many. It's a widely used method. It is an accepted method because everyone who is giving his thoughts and voting, it will be anonymous. This is the first step, and it will be circulated many, many times because I may have an opinion in survey one after reading the comments of other experts. I may make up my mind again and modify my discussion. So it allows and encourages the participants to reassess and revise their own opinions. The recommendations will be classified according to the type of recommendation. Either it is adapted from guidelines without any modification, adapted with a modification, or developed de novo based on expert opinion or earlier publication study design other than RCT and systematic reviews. It will be also classified based on the level of agreement and the strength of recommendation according to the level of agreement, the mean level of agreement of our experts with each recommendation, as it will be measured on a Likert scale. We will take the mean or the average level of agreement for each recommendation to classify them into strongly recommended, generally recommended, or maybe recommended in specific situations. And finally, and the most important step, will be the resource-oriented grouping for the recommendations, because we have recommendations that should be applied regardless of the resources setting we are in. This is a minimal requirement that every patient of level of healthcare that every patient should receive. We have recommendations that are representing the minimal level accepted for proper management. This will be in the restricted resourcing, and we have the non-restricted resources setting, which everything is available, everything is accessible, and also this will be another classification for the recommendations. It is still a challenging situation, yes, because the dissemination and the implementation of these guidelines, even after further revision, it will still be a challenge. No clear cost effectiveness studies for most of the healthcare interventions. So when we are going to identify what intervention should be limited to restricted resources and not or non-restricted resources, this will be quite subjective, and we will always face unusual case scenarios, as in cases of severely deprived healthcare systems. So I think I tried hardly to convince you with our project. I would like to hear your comments, and thanks for listening.